Welcome to another episode of our Airway Academy podcast. I'm Dr. Stephanie Joy Sweeney with my co host, Dr. Sarah Johnson. And at Airway Academy, we're simplifying dental airway education. And we are so excited today to have a very special guest, world renowned ENT, especially in the airway world, Dr. David McIntosh from Australia. And we just cannot wait to have deep dive more into this conversation. Sarah actually is who originally reached out to Dr. McIntosh. He was very influential to her early in her career, and I'm going to let her kind of tell a little bit how we got involved with Dr. McIntosh.
Yeah, so I don't want to speak too much about myself because we have this amazing guest here today that I really want to kind of let him share his story and what he has done. But definitely made a big impact on my career. I was one of those dentists that didn't believe that every kid, if we could avoid surgery, we were going to avoid surgery. And I sat down and talked to Dr. McIntosh. I can't say McIntosh, and showed me some studies. And one of those studies that I want Dr. McIntosh to hit on is a study about kids with ADHD and the impact of taking adenoids and tonsils out of kids and how it related to ADHD. So, Dr. McIntosh, if you'll go into that study for me and talk to me, like when you saw that study, did you expect to see the numbers that you did related to adenoids and tonsils and airway health?
Okay, well, first of all, thank you so much to both of you for having me. I really appreciate the opportunity. And this is a fantastic initiative just to, shoot the breeze and have a good chat. So, the one that you've brought up, so that's the research paper that was published in 2006. I'm pretty sure it came out of Chicago, but it was the Shervin's group. And essentially, let me just sort of paint the picture. So, this is a group of kids who, at the time, had been, suspected by their parents, assessed by ENT, and this is all just paradigms at the time. Had a sleep study that proved that these kids had obstructive sleep apnea. So that was our starting point. And these children were scheduled for surgery, but prior to that being done, these children were then sort of detoured via the psychiatry and psychology department of the hospital to have an appraisal based on the diagnostic criteria at the time for ADHD. And there was a huge number of kids that ticked all the boxes. Okay, so on paper, because ADHD doesn't have a blood test, it doesn't have an X-ray, it really just has a tick the box, process. These kids, ticked a lot of boxes, and they sort of said, "Well, you got a lot of kids here with ADHD," and then that was sort of put on hold. These children proceeded as planned to have their surgery, which again it was tonsils and adenoids. That was the paradigm at the time that we only sort of focused on, and that we've evolved since then. But this is all just in the moment. And then they looked at these kids 12 months later, so a year after the surgery. They basically did all the same testing for the ADHD, ticking the boxes, and in half of them, the ADHD was gone. Okay. Now, where people trip over themselves when they look at this is they say, oh, surgery can make ADHD go away. Now, that's not true. Okay. What surgery does is it alleviates upper airway obstruction, improves breathing, and improves sleep. It improves daytime function as a result of all of the above. And what that means is these children are then back to functioning normal. So the issue is not really what people misconstrue this as, is that, oh, if your child has ADHD, we might be able to cure it with surgery. What this demonstrates is that these children could be easily misdiagnosed with ADHD.
It's funny because you talk about the misdiagnosis of ADHD, but sometimes I think we miss the diagnosis on even airway. So many, I'll say, at least in the United States, we're taught as dentists that okay, we treat expansion, we get the airway open, we get the craniofacial development going, and then that's going to fix all the problems. And that's honestly when I first started, that's what I thought. You changed that view for me. So I've learned now that craniofacial growth is only one aspect of this. Can you talk about what ENTs, because I think not all ENTs see the world in the same glasses that you do in the airway view, but can you talk about the impact of what you do and you screen for as an ENT does with sleep disordered breathing and OSA, and how, how dentists are only a part of this process.
If we take 100 children, okay,
Right
and you
here.
blindfold me, all right, I'm not allowed to clinically assess these children. I'm only allowed to do one thing. We'll take the blindfold off for the moment that I do it. All I'm allowed to do is do tonsil adenoid surgery. That's all I'm allowed to do. I'm not allowed to do anything else. In doing that, I will fix 80 children, okay? I will fix 80 children without any clever assessment, any diagnostic, anything, because that's just the numbers game that we're playing. Now, of those 80 children, 80% of those will stay fixed. Okay. So, what that means is 80% of 80, just to do your math for you, is 64. So, overall, two-thirds of kids, if we just do tonsils and adenoids, they get fixed and they stay fixed. Now, what's happened is we've become aware of the ones where surgery doesn't fix or does fix but relapses. And that's been conflated into surgery doesn't work or surgery is only temporary. And this is the selection bias that we can have, especially when we jump the fence into the dental world, simply because you have this fabulous thing of expansion and everything that goes with it. And you're not going to see the 64 kids that got better and stayed better. Okay, you're going to see the kids that had surgeries that it didn't work, or you're going to see the kids that had surgeries where it did work, but things crept up later on from a jaw point of view, and you're going to get a biased selection then as to what your world looks like. Previously, it might have been, maybe one every 10 kids. Now it's close to half. And again, it's a selection bias that I have. Not half of children, have nasal allergy problems, but half of the children that I see with airway problems, breathing problems, jaw problems blended together have got these allergies in the mix. And that's why people like yourselves are seeing this a lot more than, I used to see 20 years ago, which is why your contemporary exposure to history at the moment is very different to mine in terms of what your foundations that you're building on. You're building on a very different population group now than it was even 20, 30 years ago.
I feel like in this profession, when we're learning about airway as a dentist, we go into most of the courses here in the United States are, you learn this, you do this, you learn this, you do this. And we kind of piece together everything as we go. And 10 years ago, when I was learning this stuff, I didn't have the knowledge that I do now. And you're a part of that puzzle piece, and so many patients will come in and they'll talk to me and they'll say, we have a lot of these what we call crunchy moms. I'm a semi crunchy mom, but we have crunchy moms here in the United States that walk in and they say, I want to avoid surgery. Like, I've heard that airway fixes adenoids and tonsils, and I don't want to remove them because it affects their immunity long term. And for the longest time, I said, yeah, like, I want to do that too. But then I attended your lecture and I listened to the things that you were saying and the impacts that it had on brain development. And I said, I'm missing a piece of the puzzle here. And some of these kids that I was treating that were not getting better just through expansion, they would be a little better, but they wouldn't be 100% better. I was missing the mark. And you gave that to me and made me realize this path that I was going on, I needed to expand my view. I needed to have a team involved in assessing these kids. I can't do everything and I cannot claim to do that. So I love that you're talking because what you're doing right now, we have parents listening to this podcast, we have dentists listening to this podcast. So your knowledge is what we want to spread to everybody out here.
Well, and I think we have a lot of dentists that are just getting into airway. This isn't something that's taught in dental school, in the US at least. And so it's stuff that we're learning after school, and starting to integrate into having those conversations with parents, because there's a lot of parents whose kids are suffering and the parents don't even realize, right?
Mm.
They're just maybe tested for ADD or ADHD, getting treatment for that, and that's about as far as the parents are going, because no, they're not aware that there are other options. And so a lot of times dentists here in the US might be the first ones educating a parent about their child's airway issues, um, and What would you say is some great advice for a dentist that maybe is bridging that conversation and is trying to encourage a patient or parent to take their child to an ENT?
What I want to do is for the parents part first is give you the big picture right here, right now. The big picture is the majority of these children need surgery, okay? And then a good portion of these children need surgery and orthodontics. A small portion of these children just need the orthodontics. And when I say orthodontics, I'm talking about expansion, okay? But also just be mindful that allergies can't be overlooked now too, all right? The conversation's always been about expansion versus surgery. It's actually the wrong conversation. It's expansion and surgery. There is published research from way back in the 90s showing that doing the surgeries, the tonsils and adenoids, can result in improvements in the dental skeletal alignment. You can get resolution of cross bites and open bites and all sorts of things without any dental or orthodontic treatment. You just got these airways better, got these kids breathing better. Okay. Now, that's not every child, and it's not every case. But when we spin it around and look at the other way, we say, well, look, if we can do expansion, can we avoid surgery? And the short answer is you can't, as much as you might want to. And there's a few reasons why. The first reason is parents underestimate how much time they have up their sleeve. And we've got some really good research, and it's been replicated you've got the UK, the USA, and Canada. So we've got three respectable countries doing respectable research in big numbers, which have collectively and collatedly shown that you've got 6 months to help these children from the time that their airway problem starts to the problems that permanent changes start to set in. You don't have 6 months to play with, hoping something is going to work. And when people talk about, the tonsils and the adenoids, they're part of the immune system. If you want your immune system to work properly, you got to get good sleep.
Hmm.
Okay? Having upper airway obstruction is deleterious to your immune system. So this is, actually the paradox that parents say, "Oh, I don't want my child's immune system being impacted." Well, then the answer is get them breathing and sleeping better, because it is being impacted right now. Your child is not breathing properly, they are not sleeping properly. And as a consequence of that, your child's body is in a state of inflammatory processes galore. And there's a multitude of ways that we can measure this and demonstrate it. Your child's immune system is dysfunctional if your child is not breathing or sleeping properly. That's actually the real problem.
Well, I think we've been chatting a lot about how we can help the kids. But I think, I know that there's actually still a lot we can do for an adult as well. It's a bit different, and I think a little bit different maybe in the order of procedures. So, we talked about it really is very important to make sure that kid is nasal breathing even before you start the expansion process. Now, in an adult, uh, things like turbinate surgery is maybe okay, but maybe getting a deviated septum straightened out before doing expansion can cause the expansion to have more likely to have side effects. So I think it gets a little bit more complicated when we start working with adults. What advice do you have for dentists that maybe are helping patients who are looking to get to the root cause of their sleep apnea and stuff and go through um, more aggressive treatment, combined ENT with dental expansion as adults?
What are the contributing factors to this person, so that we can understand everything? So, if they have, for example, a blocked nose for whatever reason, and they happen to have their tonsils that are very big, and they've got signs of reflux, which can contribute to nose and tonsil problems, and they have skeletal deficiencies and they're overweight, well, it's a bit like the child, scenario. Which one of those do we need to fix or manage? All of them. Okay, we need to manage all of them. So that's why I can't fix it by myself. You guys can't fix it by yourselves. Weight loss won't fix it by itself. They're all contributing factors to the disease, so they're all contributing factors to the solution. And what someone like myself as an ENT can do is we can start to basically put the strategy into place. I will look at someone, and I go, look, your nose is no good. We need to get that sorted. You need a nose that works properly. If you want to look at using nasal CPAP, well, your nose needs to be unblocked. If you want to look at using a mandibular advancement splint to tolerate that, your nose needs to be unblocked. So we're going to get your nose sorted. Now, I can see some changes in your throat on the back of your tongue due to reflux. So we need to start managing that as well. I can see that when you bring your jaw forwards, that your upper airway is a lot better for it. So a mandibular advancement splint is going to be important. But by the way, you also weigh 200 kilograms. So reality being what it is getting your nose clear and wearing a splint is going to facilitate the CPAP rather than anything else. It's going to help that work better. And with that better breathing and better sleep, you're going to have to work on better health, and we need to get your weight down. But to do that, we need to get your breathing and sleep better so that your whole body hormone, your food seeking behaviors, your energy levels are optimized to help you lose weight.
And you talked a little bit about, like, in fit females, that it can have to do with muscle tone. And I know that also that gets worse around perimenopause and menopause, right? There's a hormonal connection to that.
Correct. Yep, and the nose gets worse too. So as a starting point, for a whole lot of reasons, women in this conversation are behind the eight ball. So our diagnostic criteria. So we're looking for basically snoring, waking up tired, having troubles with concentration and focus, and so forth. Whereas women, it's more that they just wake up and they've got brain fog, and they have some sort of they start to forget things a bit, and that's all gets sort of put down to menopause, perimenopausal stuff. But what happens is that estrogen changes lead to the nose getting blocked, and progesterone changes lead to the lower airway collapsing more. And one of the other dynamics in women is what's called the threshold, that basically it makes you disrupt your sleep. So for women, lesser disruptions lead to you waking up through the night. Now, these may not be conscious wakings. You're not, aware that you've woken up, but you actually have. Like if we measure your brain patterns, it shows that you're awake. And minor disturbances are easier to cause that to happen. So that's often why in the male female partnership, um, the woman notices the guy snoring, but the guy doesn't notice the woman snoring. And that's another reason why women get missed, is because the bed partner, if it's a male female matchup, the male has no idea because they just sleep through it all. So the female doesn't get that partner feedback, whereas the other way round, the female is very, very aware that the guy next to them is snoring badly. This is why, especially around the menopause time, when those little things that weren't so bad for a woman from an anatomy point of view, they start to escalate, but they get fobbed off as just being, oh, brain fog is part of hormone changes. This is all part of it. Yeah, 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 oh, yeah, that's part of it too. Yeah, it all just gets fobbed off. No one really asks about breathing or sleep, and then when they sort of click to it, and it's managed, they just feel so much better.
How do you recommend for a woman who maybe thinks that she has these symptoms and wants to find out, could this be the cause? What would you recommend that she start with?
The vast majority of women actually are falling into the upper airways resistance syndrome. So your clues there are that you're mouth breathing, that you're noticing that you're getting nasal congestion, you know that you're not getting great sleep, you're waking up, with headaches, brain fog, trouble with concentration, memory, those sorts of things. You've in the journey had a sleep study which was normal, so you thought you were normal as a consequence of the same. What you really need to do is honestly see an ENT. An ENT will look at the nose, look at the lower airway, and often, like I said, this is a dual management. This is a management between myself and a dentist. And and then the often myofunctional therapy in the mix as well. So then it becomes the three of us to adequately address this. The paradox is that women are far more vulnerable to being affected by upper airway obstruction, and they're far easier to fix.
So we could probably sit here and talk about this for days. It's fascinating, and I love the collaboration. But one of the things that I wanted to make sure that we ended on and talked about was how can we as dentists collaborate better with you ENTs? What do you when we refer a patient over to you, because I think it's not our wheelhouse to tell a patient that they need surgery. I think that's the ENT's wheelhouse. How can we kind of collaborate with you guys when we send referrals over to you? What kind of things do you want to see in those referrals, to make sure that when you're speaking to these parents, they're teed up for the right conversations, or even adult patients, like they're teed up and ready for you guys so that we can collaborate better with you?
So ENT is a very big specialty. And the first thing I think, from your point of view, is you've got to make sure you've got the right ENT on the team. All right. There's no point having the best soccer goalie if you're playing gridiron. Okay. Both of those people are footballers, but you kind of they're not the same type of footballers. Okay. So from that point of view, I think that's important. And to do that as your starting point, I think you need to find that right ENT. And in doing so, that ENT will tell you what they want. You kind of, making life easy for yourself. One, because you know the ENT and you already know what they want. And they might want something different to what I might want. But if you already know what that particular ENT wants, just give them what they want each and every time. But to do that, you've got to know your ENT. And you know, this is not unusual in the dental profession. If you think about all the pathologies as a general dentist, you might come across someone that needs an implant. Well, you have someone that does that. You might have someone that you find a lesion that needs excision. Well, you'll have someone for that. You might have someone that has got really bad root canals going, and it's like, this one's not for me, and you'll have your endodontist for that. And then you'll have your pediatric dentist, and you'll have you have your team, but you know that you might need different people for different things. So you might have oral maxillofacial surgeon that only does wisdom teeth. Well, okay, that's the wisdom teeth one. But you have another one that does a lot of the cancer ones. Now they're both oral maxillofacial surgeons, but one does cancer, one does wizzies. Okay, you've got two of the same specialty for different reasons. And ENT is no different. You might need an adult ENT and you might need a pediatric ENT, but they've got to be airway ones. And I can't do the heavy lifting there. You've got to do that part of it yourself. And what you're looking for is probably more of an easier and better answer, rather than, what does the ENT want? Well, the ENT wants whatever they tell you they want. So listen to them. And if they say, look, I don't really do this airway stuff, don't try and make them do it. They're not going to do it. All right. They just made life easy for you. And in some respects better, because you're not going to send a patient there. And then, they're not going to come back and go, that ENT said that, they don't do that. So why did you send me there? Well, you already knew not to send them there. So you saved yourself some grief. So what are you looking for? You're looking for either an adult or a kid. Some like me do both, but each to their own. And it has to be someone that is aware of all these contributing factors. Not just the ENT part, but they know about the orthodontic jaw part. They know about the myofunctional part. They know about the allergies and so forth. They understand the list. They understand the dynamics, and they're proactive about it too. They're not yeah, I saw them with big tonsils, but they can get better by themselves sometimes. So we'll see how that goes. Because that's not what you want. That's not what that child needs. So once you've got that sorted, then everything else kind of flows on from there. And the other thing, maybe this is just cultural, but here in Australia, it's not unusual for people to drive, let me put it into your language, 500 miles one way to see someone because there's nobody where they live. or there is, but it's not quite what they need. And so there's a far greater acceptance of traveling, at least here in the Australian culture. I'm not sure what the American culture is, or whichever country you're listening in on. But what I would highlight is, if you want to see someone that's best suited for your needs, that may mean one, traveling, and in the US context, it may mean seeing someone outside of your network. Okay, because if you're seeing someone that's inside your network, they're probably all constrained by that network's rules as well. And a lot of these US based ones, they mandate that you have to have a sleep study, and if the sleep study is normal, then there's nothing wrong with you. That's not true. It just means that they won't pay for anything that involves getting you fixed. It's kind of like their get out of jail card, where they can save money because they know that they can save money, because they know that they're excluding a good cohort of the population based on a test result that is not reflective of whether you have a problem or not. It's just whether you have a problem or not that meets their threshold for helping you. And if it doesn't, well, you're on your own. And in which case, you might as well be out of network anyway. So, in some respects, it's a conditioning of insurance rules that leads people to treatment outcomes as well, and that can be really hard to break the mold. So I can't solve that. I just want to shine a light on that. So long story short, you might have to travel, and you might have to do it out of your insurance network if that's a thing for whichever country you're happy to be in, if that's the case. And it's not unusual. People travel. People from Australia will go to the US. They will go to the Mayo Clinic, because they're just not getting answers. And they will stump up the 20,000 US deposit that you need just to walk in the door there, just to have that first conversation. So that's obviously an extreme example.
Sure.
But it does happen. People will travel for their health and wellness, one way or another, if they're not getting there. So again, just have that in mind as a potential necessity, so that if yourselves then as dentists, when you've sort of looked at the landscape and done the survey and go, what, we got six ENTs right next door to us, but not a single one of them is airway focused. But we've got one that's across town, that is. Well, look, I'm going to explain that to the parents and say, look, you know, sometimes there's what's convenient, and there's sometimes there's what's best. And from our experience in this context, you know, if you'd broken your nose, look, any of those ENTs next door, they'd be great for you. But for this thing, for your child, we've actually found someone that actually is better suited to what we think is your need. As to what you want to use that information for is up to you. But what do you do? If you want to find out about what's a good car, you go and ask a mechanic. Why? Because the mechanic knows what's a good car and what's a bad car, not the car
Yeah.
dealer. The car dealer knows what's good for them to sell. The mechanic knows which cars you would never buy because they're just a nightmare. They're notorious
Mm-hmm.
for having problems. So it's kind of the same. You guys are kind of the equivalent. You've got no vested interest in recommending an ENT other than it's the best model that's suited for your child. Just like the mechanic can say, yeah, look, if you want to buy that car, you're buying yourself a whole lot of problems. That's on you. But if it was me and I had the same money, I'd go and spend it on this car instead. And that's just an analogy that you can play with. That might just help the parents understand why you're suggesting someone that is geographically inconvenient but professionally perfect.
Well, you've had some wonderful analogies that really do help to simplify these things. I think these comparisons are definitely ones I know I'm going to keep in my toolbox to share back with my patients. Hopefully, a lot of the doctors listening also are going to have some great takeaways from this conversation. I know I learned a ton, and I am so grateful for the opportunity to have had this conversation.
And I am too. I follow you. I tell everybody about you. I tell my patients about you, and it's just great to be able to hear from you again in person. And I know Australian time is like, I don't know, we start 6 o'clock in the morning there, 7 o'clock in the morning. But we appreciate you getting up so early to be able to talk with us and help us kind of tell the world about what you're doing and how important this collaboration is between ENTs and dentists.
No, thank you again for having me.
Yeah. And if you enjoyed this podcast, please be sure to like and follow our channel. We've got lots more great guests coming, and we are so grateful and so excited to help educate all of y'all so that way you can help touch more patients in your community and help treat more children and adults and help everybody start breathing better.